Thank you. Thank you. Can you all hear me? We all good? So thank you very much. I want to thank the organizers, especially Dr. Sheltut, for inviting me. I have been here. I need to use the microphone. Okay. Thank you very much. That's much better. I was here in 2019 and then was not able to travel because of the COVID-19. So glad to be back in Egypt. Wonderful country. And you have beautiful weather for this conference. So I'll try to keep on time. I have, since the last introduction, I have moved. So now I am at a different university. I'm the section chief of endocrinology at Virginia Tech Carilion School of Medicine. So if this works, yes? Yes. Ooh. Yeah, so this is the medical school that I work and teach at. We have 5 endocrinology associates there and residents, and we are actively looking at type 1 diabetes and insulin pump therapy with our colleagues, University of Virginia, about an hour down the way. So if you're ever in Virginia, please stop by and I'll be glad to host you. I have no financial disclosures, and you may take pictures of these slides. So what are we going to do in the next 20 minutes? We're going to talk about a little bit, just real quick, because you know of this. I just want to give you a brief update. The history of insulin pumps and sensors, and we're going to look at all the insulin pumps and sensors that are available in the United States. There may be an insulin pump and sensor that you have available in this country that we don't have in the U.S., and I'll talk about some of them that are going to be approved, hopefully soon. We'll also talk about CGM and the value of CGM. And finally, we're going to talk about how close are we to that closed loop system, the bionic pancreas. And I will tell you, we are on the verge of having a completely closed loop bionic pancreas. It will be here within 5 years. We will have this ability. So I'll talk to you a little bit about that. So before that, I wanted to show you this beautiful woman. This is my daughter, who graduated from Columbia University, and this is on a trip to the beach. And I show this to show you what a beautiful daughter she is and how great. But the other thing about her is she was born in 1993. So she's not that old, you know. Something else happened in 1993. Does anyone remember what happened in 1993? Yeah. DCCT. Because before 1993, we didn't know that treating diabetes type 1 did any good. And the original DCCT trial was in 1993, randomizing people to conventional insulin therapy, A1C of 9.1, to intensive insulin therapy, 7.2. Intensive therapy in 1980 in the United States was pork, beef, N, and R. And if you had a pump, it was Velocilin. It was buffered regular insulin. It wasn't Lispro. So again, this is really crude methods. We were able to get the A1Cs down to 7.2, and we found significant success, that there was significant reduction in microvascular disease, retinopathy, neuropathy, nephropathy, all the way down to a hemoglobin A1C down to the 7s. But of course, when you got that low, you had a complication, hypoglycemia. Whether you were in the intensive control group or the conventional group, as you got below an A1C of about 8, significantly more hypoglycemia. So how can we get our patients, our type 1 patients, to have a hemoglobin A1C of 7 or less while avoiding hypoglycemia? Well, one way we can do it is insulin pumps. And insulin pumps have been here since the 70s. The big bricks that we have, of course, in the 1980s, they became smaller. In the 1990s and 2000s, we got the integrated system with the CGM, and now we have a CGM and insulin pump device. Who's using insulin pumps? Well, in developed countries, they're more common. In the United States, about 20 to 30% of all type 1 patients have an insulin pump device. UK, and my UK colleagues can probably give me an updated number on this. The published report was 15%, but that was about 5-6 years ago. I would suspect that number is probably more like 30%. And in certain countries in Europe, Germany, Austria, it's over 50% of patients who have type 1 get an insulin pump. And insulin pumps do great. They lower glucose, they lower A1C, and also, in this study in JAMA, they actually prevent hypoglycemia and diabetic ketoacidosis. Study looking at patients with type 1 diabetes, randomized to pump or glucose monitoring, insulin injection, less hypoglycemia, less DKA, less severe ketosis. So pumps really seem to help a lot. Let's talk about CGM. CGM's actually been around only about 20 years. First, you had the CGM device, which the patient couldn't see. You had to download it, and then you'd see the numbers, and you go back. The Dexcom was the first one to have it, then Freestyle Navigator, 5 days of data, and now you have multiple monitors that are out there. Some of the older problems were accuracy, a time lag, since you're checking interstitial glucose, right? It's not capillary venous glucose, it's interstitial glucose. So you have to wait for that to happen, and then you translate it to a change, the signal. Now, as CGMs have gone through the time, you can see they've gotten much better in terms of the accuracy. Accuracy initially was about 20-25% in the old Gluco Watch or the Guardian system. Some of you remember those systems. To now the Eversense, the Guardian, the Libre, they're all within that 10% accuracy. So the accuracy is much better. These are some of the CGMs that are available in US. The Libre by Abbott, the 2 and 3 are available. The Dexcom G6 is available. G7 is going to be available. It's available in Europe, not in US. Guardian 3 is the MiniMed system. And the Eversense is an implantable CGM where you have a little pellet, so to speak, that is inserted under the skin and sends a signal. You can use this up to 6 months in Europe, only 3 months in the United States. Here's a question. For those of you taking care of type 1 patients, if you had to pick pump or CGM, you only could pick one, which one would you pick? A lot of people are saying CGM. They must have read the studies, because the answer is yes, CGM. And this is a very good study I want to spend a second or two on, looking at patients with type 1 diabetes, A1C about 8.5, randomized to just injections of insulin and finger sticks, pump plus finger sticks, injections plus CGM, or pump plus CGM. And you can see when you change from injections to a pump by using finger sticks, you really didn't have any difference in A1C. Pretty much the same values. It was maybe a little bit more convenient, maybe you had less hypoglycemia, but the A1C didn't change. However, when you use CGM, whether you use the pump or injections, significant reduction in CGM. So CGMs, more than pumps in type 1 diabetes, improve glucose control. So how can we close the loop? We have the pumps, we have the CGM, let's close the loop and make it a plug-and-play system. In the United States, there are 2 or 3 major systems available. The 670G is the Dexcom system, the Tandem Control IQ system, and the Omnipod 5 system. These are 3 companies that have a paired CGM pump plus algorithm to make the math and control the pump. The 780G is coming. The iLet, we're going to talk about, that is a totally closed loop bionic pancreas system. And also I want to talk to you about Tide Pool and the do-it-yourself loop, because all these systems are proprietary. You have to spend money to get these systems. So there's a lot of smart people out there, a lot of engineers that have diabetes, and it's just an algorithm. It's just a math program. Why don't we have our own math program and not sell it so the world can take advantage of it? And that's why these do-it-yourself loops are coming out, where you can get this without having to pay. The CAM APS and the DiaboLoop, these are not approved in the United States, so I'm not going to talk about them, but they are approved in Europe, so if you go to other European countries, you might see them. The Dana insulin pump is also a pump that we don't have in the United States, but it is popular outside of the US, and it does have a paired CGM with it. So,
does this help if you have a insulin pump? Well, this is a study about 10 years ago in U.S. by Ray Bergenstahl, looking at A1C with a sensor-augmented pump versus insulin therapy, and you can see significant reductions in hemoglobin A1C and also less hypoglycemia. So pumps plus sensors do better than injections. Okay. What about augmented pumps versus just wearing a pump and sensor? And this is studies done by Stacey Anderson, who's at University of Virginia, looking at the shaded lines and the triangles, and they're showing the average and standard deviation of the glucose when you're just wearing the pump and sensor, and the dark lines and the dark shade, that's when you're wearing the sensor augmented pump, where the pump is actually changing by the algorithm. You're not touching it. And you can see, especially overnight, better glucose control, very nice tight glucose control. The problem is when you eat, if you don't put the carbs in, the algorithm just isn't smart enough to catch up. So better glucose control, less hypoglycemia, but you still got to count carbs. I just want to talk a little bit about these systems, just so you know. The Omnipod 5 pairs with the Dexcom, and what it does is it changes your rate every 5 minutes. So the sensor looks at your blood sugars, makes an adjustment every 5 minutes, increases, decreases, or pauses. So if your blood sugar is less than 70, or I guess that's 5 or 6, it'll stop the pump, wait for the blood sugar to go up, and then restart it. So if you're wearing the pump and sensor, there's no hypoglycemia. You basically can't have hypoglycemia. It's impossible. It avoids hypoglycemia. The Tandem pump does the same. This is the Tandem insulin pump. And it's hard for me to not have these company names because they're proprietary. They have a basal IQ or a control IQ system. That's their proprietary algorithm, which again adjusts the insulin every 5 minutes, suspends if it's low, and comes back up. The control IQ works in the other way and makes one correction every hour. And of course the MiniMed, their proprietary technology is called SmartGuard technology. And again, it's getting the sensor value, making changes every 5 minutes to your rate without you touching it, and adjusting the insulin dose up or down. So, are these any helpful? I think we've seen that before. This is a MiniMed study looking at patients who have a pump and sensor and are doing the math themselves versus those that have the algorithm. And you can see, if you have a pump and sensor, you're doing pretty good. Time in range, 63%, right? But if you use the computer, you do better. Another 10% time in range without having any more hypoglycemia. So it seems like these sensor-augmented pumps are really helping patients get to goal while avoiding hypoglycemia. Again, the Omnipod, the MiniMed, and the Tandem IQ. These are all the three that are available in the United States. Now, these all use insulin. And some people have said, why don't we add glucagon? So there's been some studies looking at dual pumps, where you get both insulin and glucagon. So if the blood sugar starts going low, you can get a little infusion of a glucagon, and then you won't have hypoglycemia. This is one study published in Lancet about 5 years ago looking at this. This is a small study, and we don't have a lot of data, but basically, if you look at hypoglycemia compared to conventional insulin pump therapy, significant reduced amount of hypoglycemia either in a single or a dual hormone artificial pancreas. So it doesn't seem that addition of glucagon really helps that much, especially when you have that shut-off feature. You don't really need glucagon. All you really need to do is stop the insulin. I'm going to try to stay on target here. I pride myself on being on time. But I definitely want to touch you about this closed-loop system. This is the iLet bionic pancreas. The algorithm is initialized just by putting the patient's weight in. You don't put a basal rate, you don't put a bolus rate, you don't put an insulin in the carb rate, you just say 70 kilograms, and that's all it needs. You don't have to count carbs. Right now they're looking at an insulin only and a glucagon device. They're not available, but the data looks really good. Again, okay, 5 minutes really good friend. Only uses patient weight, automatically adjusts, and last slide I want you to be aware of, every dose of insulin is determined by the bionic pancreas. You can't change the rate. Either you as the patient or you as the physician, it's changing every 5 minutes, so it's really hard to change. The computer already takes care of changing the rate. All you do is put in the patient's weight. So this is a pivotal study design. 13 weeks, and then recently 26 weeks have been published in New England Journal. And I'm just going to go through the demographics. Again, most white, non-Hispanic, but a significant minority of non-white, non-Hispanic. Most of these people already had CGM. About half of them already had a pump. And A1C in the standard group really didn't change. Not bad, 7.6. But if you had the bionic pump, you went from a 7.6 to a 7.1. We're really getting close to that 7 or less number. And we're doing it without having hypoglycemia. The amount of severe hypoglycemia was definitely less than 1%, less than 0.5% in either of the studies. And this is just a reference for that New England Journal article. It was the lead article in September's New England Journal about the bionic pancreas having better glucose control, better A1C, without any carb counting, without nothing at all, just putting a patient's weight on. So how can we get this technology to people that can't afford it? Well, I talked about one group project by the JDRF. There's two companies, one's called Gluco, one's called Tidepool. Tidepool is a free web service. You all can get a Tidepool account. Just go on Tidepool, put your name and information in, and you can upload any glucose monitor, CGM, or sensor. You can also send this to your provider, and if your provider has an account, they can get your data from at home. So you could be anywhere in the world, go to Tidepool, click your little device in, and your provider can see your glucose levels. What Tidepool wants to do is get enough data so they can have this available. You have any pump, any sensor, have a do-it-yourself algorithm, and you won't have to buy an algorithm from a company, so you can get this more available. What's also coming? Digital twin. So this is a personalized insulin therapy where you wear a sensor, a geolocator, and a glucose monitor. And the geolocator tells you where you are and what restaurant you're going to. And then it takes a picture of the meal, and it tells the pump how many carbs are in the meal, and it automatically adjusts your insulin. It also has an accelerometer, so if you go for a run, it automatically decreases your insulin. So this is something that's coming out. There's going to be a total AI system where you just wear the system with a sensor and a geolocator, and it can basically do everything for you. So availability of hybrid insulin systems is an area of growth. The do-it-yourself system is coming out, and I want to end with one more way that we can use CGM and pumps. You know, not everybody can afford a CGM, but maybe the hospital could afford a CGM. And at University of Virginia and also at Cambridge, we're looking at ways we can get patients who have type 1 diabetes who are admitted to the hospital a CGM and a pump, and either a computer, or in Virginia we're using a handheld algorithm to manage type 1 patients in hospital. So you could reuse these. You know, the sensors are disposable. So if a patient comes in with type 1, hook them up to a CGM, hook them up to a sensor, do the algorithm, and the type 1 management, whether they're in ICU, whether they're in labor and delivery, whether they're having surgery, is all automated. Again, these are studies we're doing. This is the future, but as you know, the future happens faster and faster. It used to be it took 10 years to get something to market. Now it takes 5 years. Now with technology, maybe even takes less than that. So I have only 20 minutes, and I'm down to my last few seconds. So I'm going to do my last slide and then yield the floor to my colleague. So CGM devices. CGM, guys, think CGM. They're a valuable tool for patients with type 1 diabetes, even better than pumps. Advantages: lower glucose, less A1C, less hypoglycemia. Insulin pump technology is rapidly expanding. And even though you can't always afford it, the numbers will get better, and hopefully you'll get this to your patients who have type 1 diabetes. The hybrid closed lip systems are here. You can get them, and in the near future, you're going to have a closed loop system. I am going to end my talk now, and I think we'll take questions at the end of this whole session. And thank you very much.